All right, I'd like to call the folks up from Oregon. Yes? Yeah, thank you. Come on, Lillian, Janet, Diane. So while they're coming together, we've got time for discussion and questions. Oregon obviously has done a great job in helping us think about the upstream influence of this work. Still a lot to do there. I think data has surfaced in both of these examples as important pieces of work, bringing in best practices. Oregon clearly identified a number of models where that's important. I wanted to start with a couple of questions. The first one, which I think has probably relevance to both of the case studies, and that's on the issue of readiness. So one of the things that you mentioned, Lillian, early on was that there was political will in Oregon for this work. And that could be a very interesting topic in itself, what's political will. So I just want to kind of get a sense from you, what were the factors that really created the sort of perfect storm for the work that you're doing in Oregon to happen? And are there some elements of readiness that if states were really interested in taking this on that need to be in place? So that's number one. And then for Cincinnati, just interesting, you're doing a lot in terms of shifting the culture of the school. And it just struck me because often when you talk about community work, there is always this power dynamic, and health systems typically end up being sort of the powerhouse where they're driving and influencing how things happen in communities. I think this is relevant to both of you. So I was just curious, you're implementing changes in the school that obviously have had some good results, but was wondering, are there changes in the health system that's occurring because of your work in schools? Has it shifted any thinking or practices within the health system? So we'll start there and then we'll open it up. I had liberty as the moderator to get the first ones in, so you're next.
No, it's a bit of a cliche to say never let a crisis go to waste, and I think that that's really important. I think that what happens when sometimes we recognize these crises, we say things like never let a crisis go to waste, but I think there's some elements that creates that ability with political will, and we touched on them this morning with several of the speakers. One is leadership. You have to have, once you've identified that something is just kittywampus and not coming together and you're not getting the results that you want, can you identify champions that both name the sector? For us, it was the governor. It was also some of the health systems leadership, and that can kind of be kind of pushed along and say, look, this is what this looks like, what are we going to do? And then I think the other side of leadership is community, obviously community support, and making the problem make sense to the community in a way that they can actually participate in the solution. So I think that those are like three elements that really have a lot to do with it. I also think it takes a while. We had Oregon is the state that meets. We never saw a topic we didn't want to sit down and talk about, but, it was like, just bringing everybody in and doing like every Wednesday night, you remember these horrible Wednesday night meetings, but for close to 6 months, where we brought everybody in from the radiologist to the chiropractors, to the community-based organizations, to the ethnic mutual assistance organizations, and people got to weigh in so that when the sausage was made, you could say, here's how this is trying to support your concerns. Not everybody got what they wanted, but I do think that leadership on both sides, leadership up and leadership down. You want to say something?
No,
okay. Diane?
Is it on? Okay.
Yeah.
Coming from a very rural frontier town, it took a shift at the state level with health transformation and then the Department of Education saying that education really needed to work with healthcare and vice versa. And so then our superintendent was going, yeah, I really do need you. I'm supposed to work with you. What are you going to do? And that was a culture change and rubbing and smoothing each other's edges. I still have patches of skin missing from it. Yeah. I mean, that was when you get in there from public health and you're looking at like, yeah, you need to do this and why aren't you? And he was telling me, yeah, I want you to come in and audit my teachers and my health rooms. And I'm like, I don't do that. And that caused a problem to begin with. But since then, you learn who the gatekeepers are. You learn who in your community that you can go to. And I found out that the school secretaries have the most power. And so when they're on your side, it's going to happen.
Uma, do you want to touch on the will and readiness piece?
I think we have spent about 15 years working on healthcare. We also had a crisis like Oregon did, although ours was probably not the same crisis that Oregon had, and that was that in our community we were continuously building more beds for mental health, in large part because of the social context and the social crises and the lack of prevention integration. I think a very important part of our rule building had to do with the board, and we have continued to find that the board has been probably the best champion. Our board members are obviously, like many of the board members, from the community. They participate in multiple activities in the community. And what, Rob, maybe you can say a little bit about our will building. We really took the board out to visit with communities to understand what the issues were, and for the communities then to ask the board for what they wanted Cincinnati Children's to do. So that was a pretty important part of it. I think that the effectiveness of using data now has built well enough that City Council is on board, and we're actually putting together a City Council group specifically thinking about children thriving in the city of Cincinnati. So I would say most people are not ready to change, but most people are persuadable if they can see differently.
Yeah, to Uma's point about the board going out, we split the board in two. They went into two neighborhoods. Healthcare didn't speak at all. It was really just our community partners. What is it you see that works at Children's that you would like us to share? And so, for example, the 0 to 6 lead talked about kindergarten readiness. Cheryl Broadnax spoke about the third grade reading work, and it was our data, and it was improvement, and it was convening power, and so on. I think, and then did healthcare change as part of it? I still remember our chair of surgery meeting one of the school nurses presented, and literally becoming tearful, saying, I can't believe for 18 years I've been discharging complicated surgical cases into the community and not realizing there are 48 school nurses who could have been following up on them the next day. So in that sense, and we've seen that from high-level leadership, our COO spending time in the schools now, in the local school district some, all the way down to like our medical director has been the head of our clinic and completely committed to these kids, but hadn't it been inside the home of one of the families in her 10 years of leadership of the clinic. So definitely changing how we think, and it's really the parents that are doing that changing.
This is a question from the web, and it's from Rich Seitz, who is Chief of Administrative Services for Ocean County, New Jersey, Juvenile Services. And this is in reference to a different kind of the good behavior game. It's the PACS good behavior game, if you guys are familiar with that. He says, if anyone's aware of this strategy that uses school to change public health outcomes. In 2010, NIDA Chief Prevention Scientist Elizabeth Robertson said that if GBG were widely adopted by primary schools, the public health impact would be huge. And then he provides the link to that and says that he thinks the PACS GBG is used in California and Washington State. So I don't know if you have any remarks on that.
Yeah, my sense is there are two variations on the good behavior game. The PACS Institute is the one we've been in touch with. They're based in Tucson. And my sense is there's 20 years of pretty good data, to your point, behind it. And yet, as I understand it, these sort of positive behavioral intervention, PBIS frameworks the school have are very loose. And so there's not, say, uniform implementation of a highly evidence-based intervention. And to the extent we can be partnering with schools on that, that would be helpful.
Hi, Mark Garevich from the Department of Population Health at NYU, and also a member of the Roundtable. Question around the Oregon work around measurement. I think you mentioned that kindergarten readiness is the primary outcome. That's complex and differently measured in different places. How are you tackling that in a large area and thinking about that? And does it require a lot of additional resources?
So we have a strong scoring, metrics and scoring committee infrastructure that develops how we measure our goals. Kindergarten readiness is actually in the pipeline to become a statewide incentive metric for all CCOs. HealthShare is doing what we call a field definition for kindergarten readiness while we wait for the state to get there. I think there was just a meeting yesterday afternoon on finishing up this metric. And a big part of the metric is identifying what does the healthcare system, where does it fit in the kindergarten readiness space? Where do the early learning hubs fit? You know, the different segments of our community. And we all will have a slightly different basket of measures, but together the CCO with all the partners will be held accountable and incentivized around it. So I'm happy to send you our kindergarten readiness bundle work that the Metrics and Scoring Committee is doing right now.
Do you have a sense that it's costing much to acquire the data that you need for it?
No,
No.
no.
You do have a sense that it isn't.
It is not costing a lot to acquire the data.
And I would just add, this is all getting rolled up to the Governor's Children's Cabinet,
Yeah.
which includes the WIC work, you know, which addresses food insecurity, et cetera, too. So, I mean, it keeps rolling up.
So this is a question to all of you. Oh, by the way, I'm Bob Kaplan from Stanford University and a member of the Roundtable. So it's a question to all of you, but maybe we'll start with Rob. And, you know, I don't want this to be too personal, but how do you make a living?
That's a giveaway.
So I mean, the question really gets at this complicated issue that I think we deal with a lot in the Roundtable, and that is, you know, in most of the organizations we work with, and I worked for many years in a medical school, and if I was in a department of family and preventive medicine, and if another department was growing, say internal medicine or whatever, they needed a new position, we would fight till the death to make sure that one of our positions never got moved over there. And so with the idea of global budgeting, you know, moving some money from traditional services into a mental health unit, you know, people go to war over these things. And then as you get even larger, how do you actually move money from the healthcare system into other systems that might do better at producing health benefit like quality adjusted life years?
So how do I make a living? You know, it's essentially how is this work currently financed? And so I'm, you know, right now we do not have a value-based payer system, so we're not reaping revenues that way. It's really mission-based right now that the hospital made not just a 5-year commitment. So when the CEO, after these board visits and the CEO and the board spoke, they said, this is not a 5-year journey, this is a 10-year journey or 20-year journey. It still leaves, I think, all of us very cautious. Well, what if there's a change in leadership over time? I think we're very intent on doing our best to find outside funding that can offset some of this. So for example, we're working on Gates grants and other grants that are out there to try to offset it. That doesn't solve my dream, which is to have HealthShare convince CareSource, our managed care organization, to really start to think about some of these partnerships. We had a brief play at value-based payment, and they had a $200,000 or $300,000 innovation fund in which they could test some of these things. And I was partnering with them a little bit on some small-scale work that where it was truly a healthcare dollar was going directly into our legal aid partner.
So just so that I understand this, though, so most of it comes from raising new money from Gates or from some other fund, as opposed to taking that money out of somebody else's pocket at the University of Cincinnati or Cincinnati Children's.
Yeah, you know, so right now it's not offset fully by any stretch from outside. So it's an internal trade-off right? So I guess somebody doesn't know they're not getting our dollars, but I think people do look at, say, how is it that you are hiring when other parts of the hospital are not hiring? So it really is a key leadership question. Uma, do you want to chime in a little bit? I mean, you're even closer to some of these challenges.
I think the focus on outcomes is critical. I do believe that the strategy is that we show some results that will result in change in thinking. We don't have quite the governor that Oregon started with and the crisis that Oregon started with that led all of that work. But we are already lobbying the possible next governor in this space. Also, very clearly at the state level, Medicaid is it's quite obvious that Medicaid cannot deliver the outcomes necessary, and I think in large part due to the payment models that they're providing. There's also very clear challenge now from the education sector to say that they cannot deliver the educational outcomes required if healthcare doesn't do its part to deliver healthy kids to the schools. So we're having a strategic discussion with the likely next governor of Ohio and the Ohio Children's Hospitals to put together a plan around a lot of the work related to very substantial primary care changes and especially mental health prevention. Because as somebody said earlier, the evidence is pretty clear on what to do. People are stuck in the payment models of how to do it. And as the situation gets more dire, in other words, cities can't find people to fill jobs and prisons can't be built sufficiently, this may be how some of that happens. So we are currently putting together a proposal around transforming that payment model for Medicaid. Rob is right that in Ohio, we have a challenge in that the governor, really decided to build the Medicaid models through managed care organizations, which have been reluctant to come to the table, ready to get the gain, but not willing to invest in the changes. And so that's where we're kind of lobbying and working at this point in time to see that happen. There are 5 children's hospitals across Ohio that partner and work very closely together, and I think we'll begin to see some changes. Having education declare that they cannot do their job if healthcare does not do its job has been an important part of this conversation. I will say inside the Cincinnati Children's Hospital, as somebody that's been on the executive team for a long time, there's always tension and drama that I'm sure you experience at Stanford around new chairs and values that new chairs bring and are placed. This work reports into the CEO and into the board directly as a community pillar, in large part to avoid I want to say the drama around academic conversations that are often not related to results.
Well said.
And how about in Oregon? How do you deal with this? I mean, are there examples where you actually are able to, because with the common objective of making the community healthier, are there actually examples where people have moved resources from one silo to the next?
Yeah, I think one of the things we've realized at HealthShare and in our marketplace is that we need to make investments over 3 and 4 years. And when we make a commitment to invest in a program or infrastructure, it needs to give it enough time to really get fully baked. And during that time, we are always working on a sustainability strategy. We use our quality incentive metrics funds to seed fund these, but we can't count on those funds because we have to earn them every year. Some year we might not earn them. So we're constantly taking some of that money, goes out to the community, to providers that do the services. Some are invested in community organizations. I will say a difference between Ohio's model and our model is that CCOs are not Medicaid managed care plans. They're community organizations that are assigned the task of working cross-sector between the healthcare delivery system and the community to improve population health. So we don't get to just say, oh, we're Medicaid managed care. We don't have to do that. Our contract requires us to do these kinds of partnerships, and we can't choose not to. I will say in closing, one of the things that's unique about Oregon's model is that when they did the legislation that created CCOs, they required a community board. And Medicaid managed care plans just have a private board. They're a private company. They have their board. You don't know what goes on in the boardroom. We don't have that. We have community representatives on our board. Our board is prescribed in statute. So you have to be really comfortable having uncomfortable conversations in the boardroom because there's a lot of stakeholders at the table and they don't pull punches. So, yeah.
I think one example that you might find interesting, because of this work and because of the transparency in the metrics and the outcomes, even when they, sometimes we don't hit our targets, but it socializes the concept. So recently, we just had the Oregon Association of Hospitals and Health Systems just made a major commitment to affordable housing. Looking at what are the drivers with homelessness, substance use, mental illness in their population, and what are some of the upstream things that can stabilize that population. So that came out of, I think, understanding the data across the systems and also transparency in outcomes.
Sandy Magnan. So Oregon, you said a couple of things that we all kind of dream about, this concept of community accountability, not just provider accountability or something, but it's the community accountability. And then you also said, Janet, in your parting words, where we started thinking about, and I've got it correct, started thinking about Medicaid not just as a safety net, but as scaffolding to help families get out of poverty. I mean, that's a huge leap into what Medicaid is about. How did you get to that place? Do you still say that in Oregon, or are you just standing here? Yeah. And what do people think about that, or how do they react to that? How do the providers react to that? What does the community think? What does so just talk to me more about the concept that community accountability and how does that play out, and then the vision you have for what Medicaid is really about. And then the last thing is I want to know how you're going to help Rob there keep his job. So
There you go.
I actually think Diane has a better response to that. She lives in a town without a stoplight. So community has a very different meaning to her.
So I'm on the board of the EOCCO, which is the 15 counties, excuse me. And it's geographically the largest in the state of Oregon. So I think we were the first to do transformation health grants to the community. We took our incentive dollars and we said anybody can apply, but you have to have a health transformation concept that's applying to the incentive measures. And that sprung up from the community level. The local advisory councils came in, they submitted grants. I'm on that committee. We looked at them, and they had to be tied to their community. And we really focused on partnerships. You can't do this alone. It has to be a partnership. And you can't have two grants in the same area that are doing the same thing without partnering. Because community is about partnering. And that really transformed the EOCCO. They are very community-minded. A lot of the people that are on the board are from Eastern Oregon, so it matters to them.
Yeah. I think there's a general acknowledgement that, a very small part of health happens in the exam room. Most of it happens out in the community, and it's where we need to be focusing our investments and our strengthening.
But what about moving to get out of poverty?
Oh, the scaffolding concept? Yeah. Well, I think that's what they're doing in Cincinnati, is they're providing some scaffolding for some kids to improve their long-term. What all the certifiably smart people said this morning was, we know education and healthcare correlate. Yeah, health status and life, expectancy correlate. So why wouldn't we do that work? It's so obvious to us, I guess.
Well, when you come from a rural and frontier counties, how do you separate the grains of sand? Yeah. So when they're all going to the same provider, the same services, accessing those things, so how do you say you can go and you can't? So we make sure that we're using those services so we can expand those services for everybody, so it does float the whole community. So, and the EOCC is mindful of that, that you can't just expect that we're going to only do the Medicaid population in small communities, because you can't.
So please join me in thanking this wonderful group of panelists from Oregon and Cincinnati, Ohio, Midwest. We're going to take a short pause. I think we have about, I'm looking for Lena, we might have about 5 to 7 minutes to take a quick break so we can get ready for the next panel.